quite appropriate that I take over from Anne at this point and from addiction biology to the consequences of addiction. Here are my disclosures. So, first of all, it's important to recognize that there is a wide spectrum of alcohol-related liver disease. Amongst people who are drinking heavily over a prolonged period of time, almost everybody will get this feature steatosis. That means fat deposition within the liver. Actually, only a minority will develop what we call steatohepatitis, a combination of fat and inflammation, and that inflammation will drive fibrosis. So, so in 20% or so of heavy drinkers, they will get scarring in the liver, and that will eventually accumulate to move to this state that we call cirrhosis, where normal liver cells are surrounded by fibrous scar tissue. And if you continue drinking at that stage, then you may progress to what we call decompensated cirrhosis. This is effectively a form of liver failure, which can present in a number of ways. First of all, the most dramatic is what we call acute on chronic liver failure, where not only is the liver failing, but the liver failure then has an impact on other organs. So you end up with encephalopathy, brain failure, lung problems, respiratory failure, a fall in blood pressure. There's a lack of coagulation factors, so bleeding problems, and the kidney as well. All of those, pretty much all of those conditions, certainly up to the point of this cirrhosis. So first of all, they're asymptomatic. Secondly, the primary treatment is about getting people to stop drinking, and then, for the most part, then the situation will resolve, which is great. But there is this other condition called alcohol-related hepatitis or alcoholic hepatitis, which is a very acute presentation of someone who's bright yellow with jaundice. They may also have features of liver failure or indeed acute on chronic liver failure. But the onset is rapid within a few weeks after a long period of heavy drinking. And this is life-threatening, so people who are classified as having severe alcohol-related hepatitis will have a mortality rate of anything up to 30% 90 days after their initial admission. Now, there are other causes of fat deposition in the liver or steatotic liver disease. So alcohol is the main one in terms of consequent mortality, but far bigger in many ways is what we now call metabolic dysfunction associated steatotic liver disease. I apologize for the naming. It's obviously related to overeating of calories with obesity, diabetes, hypertension, and such like. And indeed can progress in exactly the same way, albeit slower, than alcohol-related liver disease. And of course, there's an overlap because there are a group of patients who have all the features of metabolic-associated liver disease as well as alcohol, and we now call that MET-ALD. As I said, I apologize for the nomenclature. One thing I want to introduce is reasonably new, is about how do we distinguish MET-ALD from ALD, as in how much are people drinking? Well, the simplest way, of course, is to ask the patient. And if you have a good rapport as a doctor with the patient, then it's usually fairly straightforward to establish what level of drinking, albeit that actually a lot of people don't know or can't entirely quantify how much they're drinking, particularly if they're drinking very heavily. Recently, some new biomarkers have been developed, and this one, phosphatidylethanol, or PEth, has started to move its way into clinical practice. So the metabolism of alcohol changes the composition of cell membranes, here illustrated as a red cell membrane. The degree of ethanol modified lipids in the cell membrane can be measured and give an estimate of how much people have been drinking, and allow us A, to classify the degree of drinking, but B, to monitor people's withdrawal, or in people who are on a transplant list, it allows us to determine abstinence. So now turning back to alcohol-related hepatitis, and for many, many years, the guidelines told us to use corticosteroids, specifically prednisolone. The trouble is that there were some controversies. Not all trials showed the same thing. This is an inflammatory condition, so the logic was that prednisolone would settle down that inflammation and improve liver function. We ran this trial, we call it stopper steroids, or pentoxifylline. There's another drug for alcoholic hepatitis. And what it showed is this. These are survival curves for patients with severe alcohol-related hepatitis with or without steroids. In the very short term, there's a small survival benefit for those who were treated with prednisolone, but it was lost. So in the long term, absolutely no improvement in survival whatsoever, which of course means realistically no benefit, which was a little bit disappointing to say the least. Now, to explain that, we've known for some time, of course, that corticosteroids increase the risk of susceptibility to infection, and infections are very, very common in this group of patients. All patients with liver failure are at risk of infections, usually bacterial or fungal infections. And what we were able to show is that some of the benefits that were gained early with prednisolone and similar drugs were lost later, because you put the patient at risk of infection, and then the infection drove them towards liver failure. So I guess one of the big questions then is, in patients with alcohol-related hepatitis, are there ways of selecting patients who might get a durable, a long-term benefit in terms of survival? And there are three options that are emerging, and I'll just go through these one by one. So we have a scoring system for severity, which we call MELD. And what we found here is that in the middle of the MELD scale, along the x-axis of this graph, then there was a significant benefit for treating patients with corticosteroids, but at the lower end, the mild disease, or at the very severe end, then steroids were not of benefit. So MELD might be one way of going forward and looking for a group who would benefit. The other is the neutrophil to lymphocyte ratio. So neutrophils go up with inflammation, and particularly with infection. And what was found here, again, is looking in the middle ground. There's a sort of Goldilocks effect here. So the neutrophil to lymphocyte ratio was low or very high. There was no durable benefit. But if it was in the middle between 5 and 8, then patients, it would seem, will get a durable survival, which is great. And the last biomarker that we've been using is one called cytokeratin 18. Cytokeratins are found in liver cells. They're part of the structure of the cell, and in inflammation, if the cell dies, then these are released into the serum, can be measured. And there are two forms of this, one which is released in all dead cells, and then this M30 fragment, which is released if the cell has a particular form of death called apoptosis. And what we found was that those who had a very, very high level of the M30 fragment had a survival benefit, but those with a low level, it was not worth treating with steroids, so it should be avoided. What if steroids or other interventions don't work? then for many years, patients with this condition were excluded from liver transplantation on the basis that they had not been abstinent for long enough. And we could debate whether that's a logical way to proceed or not. But colleagues in France and Belgium ran this trial. So what this graph shows is that if you treat people with steroids, you get responders and non-responders. Responders have a very good survival. Non-responders have a very poor survival. But if you take people who were non-responders to steroids, and that's judged after 7 days of treatment, and then you listed them for transplantation, then their survival was excellent, which is great. There are some issues, of course, or debates about how often these patients return to drinking because they've not had a period of abstinence. So in these patients, in this trial, there were a number of issues. There were only a tiny number of patients who met the appropriate criteria that was set by this research group. These criteria are considered to be somewhat subjective. In some countries, there's no legal framework for this, and it was unacceptable to some of the patient groups, which is a shame. So subsequent studies have then looked about scoring system to make selection more objective, looking at comorbidities, having an addiction specialist like Anne look at the patient, also actually questioning of the family, which is interesting because often the family has an important role to play in determining whether a patient is suitable. So transplantation will hopefully come into the UK. It's common in Europe and it's massive in North America currently. But for the time being, we're really looking for other treatments that obviously can avoid transplantation. So the question is, what is around the corner? So 3 areas I'm just going to focus on. One is the gut microbiome, because this plays an important role. The second is macrophages, a special cell type that manages inflammation. And the third is around genetic manipulation. So the microbiome. So we know that the microbiome in patients who drink heavily, and particularly with alcohol-related hepatitis, it's very, very abnormal. It damages the lining of the gut. And as a result, the gut becomes leaky and those products get into the bloodstream and stimulate inflammation in an already very susceptible liver. And this is an interesting experiment. It's a mouse experiment where they took the microbiome, effectively they took poo from patients with alcohol-related hepatitis or patients with a healthy microbiome. They put them into mouse, fed the mouse with alcohol, and showed that this exacerbated the liver disease, which is really interesting. So there have been now a couple of rather poorly designed studies looking at changing the microbiome using what we call fecal microbial transplantation, giving healthy poo to patients who have got this condition. And these seem to show a survival benefit. And then one rather intriguing study looked at patients with cirrhosis and did a similar sort of study with fecal microbial transplantation and showed here that it not only improved their liver function, reduced inflammation, but also reduced craving, which is very intriguing indeed. So we're now just setting up a large-scale trial of fecal microbial transplantation and should be able to report in about 2.5 years' time. I mentioned macrophages. These are a special cell involved in regulating inflammation. We tend to think of them as being important in counteracting infection, but they also have an important role in regeneration and liver remodeling, also in other tissues as well. So if you give healthy macrophages to patients, the idea being that these might actually reduce inflammation and help the liver to recover, This is now being evaluated in patients with alcohol-related cirrhosis. It's called the Emerald trial, and we should hear about it soon. This is there's some data here from an earlier study on macrophage therapy in patients with cirrhosis, showing that in this case, a single infusion improved long-term survival. Final intriguing treatment is based around genetic susceptibility in alcohol-related liver disease. So we know that patients who have a variant of this gene, it's called HSD17B13. If you have a variant that actually has a loss of function, then you're protected, even if you're drinking heavily, from developing liver disease, either from alcohol-induced or obesity-induced cirrhosis. And so we're participating now in a trial that suppresses the healthy version of this gene, the normal version of this gene, to see if we can protect people with both types of liver disease. Again, a trial that's ongoing. So let me finish, just summarize management of most patients with alcohol-related liver disease relies on control of their alcohol use disorder. We've got new objective tests to measure alcohol consumption. Specific therapy really hasn't improved for alcoholic hepatitis, but actually we look after the patients generally a bit better, so survivals are improving. Liver transplantation has an increasingly important role, and I'm pleased to report there's plenty of active research on new therapies ongoing. So I shall stop sharing there. Great.